Hello.
Hi, Mana. How are you?
Hi. I'm fine. How are you?
I'm good. Thank you. Sorry that there was another meeting going on. So I had to just tell him, please, I have a webinar going on. We made it on time.
What about other participants?
What is it?
What about other participants, other presenters?
They should be coming now. Yeah, 3 people is here. Okay, they're joining.
Hi, everyone.
Hello, how are you?
I'm good. How are you doing?
I'm well.
Hi, Joe.
Hi.
Hi.
How's everyone?
How are you?
Good, thank you. Hi, Pallavi. How are you?
Hi.
Nice to meet you.
Nice to see you. Sorry, Fernanda, I didn't understand. I thought you were saying you had to leave at 9. I didn't understand that something was finishing. Sorry about the misunderstanding.
No, sorry. We usually don't have meetings before the webinars, but I don't know why today we had one.
Okay.
Sorry about that.
No worries. So I hope that Rapipong will be able to join today, hopefully.
Yes. No, me too. He seemed fairly confident he would.
Yeah.
Although it's probably quite late for him in Thailand.
Yeah. So I was just thinking, can you please remind me which order you want to go? So we thought we would start with Neha, and then was it Pallavi or Manal in
Manal.
Manal? Okay, perfect. So I have the order right, and then Pallavi, and then Rapipong.
Yeah.
Okay,
sounds great. And Manon, with the questions, how just doing it? Do we allow people to
yes,
them?
I think what I'll do is that I'll start at the beginning. I will ask people to write the questions in the chat box, and if I see that there are few of them, I think I can ask them to you all after the talks. And if I see that they are many, no, not many, I'm thinking that I will ask people to speak up.
Yeah,
if that makes sense.
Good. Sounds great.
So, yeah, it will really depend on how many, the number of questions, basically.
Yeah, makes sense, man.
And if you see questions that are relevant, or so, feel free to ask and flag the most important for you.
Great.
So yeah, I think I'll try also to keep track of time. So I think we agreed that you wanted it to be about an hour. So I guess I'll stop. I will give you a warning after maybe 10 minutes, maybe 12 to allow a bit of flexibility. So I guess I'll just let you know if it overruns too much.
Cool.
And Fernanda, I will leave you introduce the webinar if you want, like last time.
Yeah.
Cool. Thank you.
Hi, everyone.
Hi, Neha.
Hi.
Sorry, I'm a bit late.
No
Zoom
worries.
crashed, but I think that's a good sign because now it won't crash going forward.
Hi, Poon.
Hi, nice to meet you.
How are you?
So actually, it's quite busy here in Thailand, but happy to join. So
Thank
good
you.
afternoon,
Great you
maybe
can make it.
very late afternoon from Thailand.
We're just gonna wait for a couple of people and then we're gonna get it started.
And maybe let's wait a couple of more minutes if people would like to join, because apparently 40 people registered, so we might wait a few minutes.
Sounds good. There are two more people trying to join, so we'll wait for them and we'll get started. Okay, so we're gonna get started. So hello everyone, thank you for registering to our webinar, Financing Healthcare Across Borders, Achieving Universal Healthcare Coverage for Refugees. My name is Fernanda, and I'll be managing the webinar today. Just before we get started, I just wanna run through a couple of housekeeping items. So if you experience any technical difficulties, please let me know and I'll be happy to assist in the chat box. You can write it down. And for questions, you're free to write them in the chat box or come off mute during the presentation or at the end. So without further ado, I'll introduce Manon Emersley, our chair today.
Hi, everybody, and thank you for joining. So I will be the chair for today's session. So I will introduce the speaker today. So we will have Neha Singh, who is an assistant professor and co-director of the Health and Humanitarian Crisis Center at the London School of Hygiene and Tropical Medicine. She has a background in public health and expertise in mixed methods, health policy and systems research, including on health financing to improve the prioritization, design, and delivery of essential health services in humanitarian crisis and under-resourced settings. Then we'll have Manal Etemadi, who is a health financing researcher in Iran, health insurance organization, and who has 10 years of experience in health systems research and also works closely with the health economics group of Iranian Academy of Medical Science as a health financing advisor and specialist. Her research concerned social health protection, pro-poor healthcare financing system, and subsidization of the poor. Manal holds a PhD in health policy from Iran University of Medical Science. Then we'll hear from Pallavi, who is a senior research associate at BRAC Uganda and is supporting research activities for the RECAP project in Uganda. Her research interests encompass health economics, livelihoods, and applied microeconometrics. Pallavi holds a master's in development economics from the London School of Economics and a bachelor's degree in economics from the University of Delhi in India. Finally, we'll hear from Dr. Rapi Pong, who holds a medical degree and a PhD of public health and policy from LSHTM in London. He has dual roles, first as a faculty for epidemiology specialist training at the Department of Disease Control at the Ministry of Public Health, and second, as a vice director of the International Health Policy Program, also within the Ministry of Public Health. He's also the head of the non-tied population research units, and his main research area are in health econometrics, health service, human resources for health, and health financing. So most of his research is related to the system analysis of non-tied population, not only cross-border migrants, but also stateless people. Aside from the research on non-tied population, he has been serving as a number of committees on many research platforms on health system and migrant populations. And then finally, we'll have our discussant today, Joe Borghi, who is a professor of health economics at London School of Hygiene and Tropical Medicine, and who's been involved in the evaluation of health financing reforms on health system in a wide range of countries. So I will pass it on to Neha for the first presentation. And yeah, I think you can share your screen.
Great, thank you. Just bear with me while I pull up my screen. Can you see that?
Yeah, that's perfect.
Yeah, perfect, thank you. Okay, let me move that down. Okay, well, thank you so much for having me here today. I'm actually going to be presenting on behalf of a study team comprising of people including Laura Mekichi, Bayard Roberts, and Joe, who's here on this webinar with us, at the London School, Felicity Brown at War Child, and Rabia Shemay from the National Mental Health Program in the Ministry of Health Lebanon. So we conducted a systematic review on mapping health financing models in protracted refugee settings and assessing their progress towards meeting the UPHT goals. We're just in the process of finalizing it, so they're mostly done, but not quite published yet. So why did we do this review? We know that the Sustainable Development Goals have committed to leave no one behind and to achieving the goal of universal health coverage, or UHC as I'm going to call it in this presentation, by 2030. There has been a lot of progress. So there's a real term increase of 61% in overseas development aid for basic health since 2010, but there's a massive funding gap in humanitarian financing. So in 2016, this humanitarian financing gap was $15 billion US. UNHCR defines a protracted refugee situation as 25,000 or more refugees from the same nationality having been in exile for over 5 consecutive years in a given host country. And by the end of 2019, there were 51 protracted crises globally, in which a total of almost 16 million refugees were living in 32 host countries. So understanding the mechanisms available for health financing for refugees, as well as the efficiencies and sustainability of these models, is an important step for policymakers and funders alike to make decisions on how, but also where to allocate resources. And this is, of course, also key for achieving UHC goals laid out in the SDGs, especially regarding essential health services and financial risk protection. So the study objectives for our review were really to map the health financing models for refugees in protracted humanitarian crisis settings, and then to assess the progress of these health financing models toward UHC goals, which I'll talk about a little more later. We also assessed the quality of included studies using a mixed method assessment tool. And just to say that this work has been done under the GOAL project, which is a GCRF and UKRI supported project. So I'm going to very quickly run through the methods, but happy to speak to it more later if helpful. So the inclusion criteria for this review was any peer-reviewed or gray literature from low and middle income country settings meeting the definition of a protracted crisis, which mentioned at least one health financing model. We excluded documents published before 2000 and not in English. And you can see we didn't have very stringent inclusion criteria because we knew from the start that there wouldn't be a lot on this topic, so we're aiming to include as much as possible. The conceptual framework underpinning our study is one proposed by Cutson in 2013 on UHC goals that health financing can influence. So to operationalize this framework, you see this table here where we define specific components and related domains of health financing models, which were adopted from the Cutson framework. And they include these domains on revenue raising, pooling, and purchasing. The specific indicators you see on the right were proposed by Mint et al. In a 2019 paper. Similarly, we operationalized the UHC aspect of the conceptual framework based on themes identified by Cutson and then Bertone in 2019. And these include service provision, financial protection, and efficiency. You can see the specific indicators to the right. So what we did is the full text papers that were included in the review were analyzed qualitatively using thematic analysis. And here, the key health financing mechanisms of revenue raising, pooling, and purchasing were examined based on their impact on the UHC goals of service provision, financial protection, and efficiency. So I'm going to whiz you through these key findings. We basically, you can see here in this Prisma diagram, we searched over 2,000 records, and in the end, we included 66 studies, 47 of which are peer-reviewed and 19 from the gray literature. Study quality, the quality appraisal found that nearly half the studies were low or medium quality. The study quality was not high. They mainly lacked rigorous study design. Some were quite descriptive, not very analytical. We had 14 case studies, 3 mixed method studies, and no purely quantitative studies or any sort of trials with controls. In terms of mapping models, we found literature related to 9 of the indicators for financing models within the 3 domains of revenue raising, pooling, and purchasing. And you can see they related to aid or overseas development assistance, health insurance, conditional cash transfers, user fees, out-of-pocket payments, tax-based revenue raising, multiple pools, private sector contracting, and performance-based financing. And these were in 13 low and middle income country protracted refugee settings. So moving on to, what is the impact of these models on UHC goals? So first focusing on service provision. We found of these 66 included papers, 11 of them related to health service provision for refugees in protracted crisis settings, but only 2 of them provided adequate quantitative data on the access and scale of coverage for refugees. UNHCR in Jordan and Lebanon actually commissioned most of the health access and utilization studies. And these studies provided the best available data on utilization rates, access, and perceptions of healthcare available to refugees. In terms of service provision, the most commonly reported barrier to accessing services was language, but also lack of awareness of the availability of services. And in some settings, for example, Jordan, we found that, the paper found that in both displaced populations, but also host communities. An example of financing model increasing coverage, which I know my colleague from Iran can probably speak a lot more to in a bit, is the Iran's health insurance scheme was introduced in 2011. And within 1 year of being introduced, 40% of registered refugees were enrolled in the scheme and granted access to tertiary care for non-communicable diseases. Overall, service provision and quality of health facilities were very poorly explored in the literature, with only 4 studies reporting the quality of healthcare services for refugees. So moving on to financial protection, our findings highlighted a trade-off between healthcare and other essential health services, or other essential services, sorry, not health services, such as education, faced by many refugee households attempting to avoid debt or catastrophic expenditure. So for example, in Lebanon, where Syrian refugees are not allowed to work legally, 55% of registered Syrian refugees in 2014 reported debts of over $400 US. Furthermore, whereas primary health care is covered or subsidized for refugees in these settings, tertiary care and referrals are not, which means that refugees with the greatest health needs are the least financially protected. However, the degree of financial protection amongst refugees in Iran is higher given that they have access to employment and are therefore able to afford or more afford premiums and co-payments required by the scheme. UNHCR here also funds the payments from health payments for most vulnerable refugees. Out-of-pocket payments for healthcare services were identified in 5 countries which had introduced user fees for refugees, including Jordan, Lebanon, Syria, Turkey, and Uganda. And so for example, in Jordan, refugees spend on average 43% of their household income on healthcare. And the removal of user fees was not linked to disproportionately higher rates of service usage, given the combination of additional travel and indirect expenditures faced by refugees when accessing services. And this is found from a global review that we included in the study. Finally, to talk about efficiency. So the increasing role of non-state actors in healthcare provision has contributed to the fragmentation of refugee health systems, which has really created a separation between services delivered in camps, largely by the UN, and those provided by NGOs and the private sector in urban and out-of-camp settings. I know my colleague Pallavi can speak more to this from the Ugandan context later. So this fragmentation has led to the creation of parallel systems and has further entrenched the reliance of governments on donors, which then increases vulnerability of the system to donor fatigue, which reduces its long-term sustainability. However, some efficiency gains have been made through technological advancements, which have improved the speed and coordination available for aid delivery for refugees. So for example, in Jordan, the CCF, or the Common Cash Facility, has increased efficiency through allowing multiple agencies access to a single delivery mechanism. There was a high initial investment cost of installing iris scanners and collecting biometric data from refugees, but those are outweighed by long-term efficiency gains of the scheme, which can be utilized for many years given the protracted nature of the refugee context. And running and administration costs for the CCF were reduced through the streamlining of dispersions from multiple implementing partners. So just to conclude, what does this all mean? Our study found that the available literature on health financing models for protracted refugee settings is limited in both quantity and quality, in particular on assessing their impact on achieving UHT goals in terms of service provision, financial protection, and efficiency. Our findings really highlight the need for more rigorous evaluations of access and utilization of financing schemes to further understand how these mechanisms or models are implemented, their effectiveness, but then also their successes and drawbacks. We also need more qualitative studies assessing the perceived quality of services from users to really assess their progress towards UHC goals. And it's interesting that of the 13 countries included in our review, all except for Central African Republic and Turkey have committed to the UHC 2030 partnership aimed at achieving the goals of UHC by 2030. However, the findings of our study suggest that these goals are not being met for refugees under the currently implemented health financing arrangements. So we need further implementation research to determine the effectiveness of current health financing models towards achieving these goals, but also if alternative mechanisms would be more effective. Thank you very much.
Thank you very much, Neha. Should we move on to Manal?
Hello, everyone. Can you see me and hear me?
Yes, we can.
Could you see me?
I can hear and see the slides.
Thank you. Thank you. Thank you for inviting me and giving me the opportunity to discuss the issue of financing health services for the refugees in my home country, Iran. Actually, I have a quick look to refugees statistics in Iran and then turn to review of Iranian health system, and then move to health financing schemes for refugees in Iran. And finally, I have the discussion on the challenges and lessons learned from Iranian experience. Actually, Iran, a big populated country with more than 85 million people, and Iran is the biggest host for the Afghan refugees across the world. Based on the statistics from the World Bank, actually Iran have the 8th rank based on the refugees population across the world. Based on the statistics in my region, Middle East and North Africa, actually after the Turkey, Lebanon, Jordan, we have the highest rate of the refugees in Iran. Actually, mostly from the Afghanistan and almost 3,000 from Iraq. But the point is that we have, this is a registered or actually documented refugees, and we have 3 times more undocumented immigrants in my country, mostly from Afghanistan. And most of refugees in my country are actually living in the urban area, but we have also 20 camps across the country with full facilities such as education and primary health services for them. Briefly introduce our health system in Iran, actually we spend 9% of our GDP on the health services, from which 4% is from governmental budget. Actually, we have 54% private health expenditure in Iran. In the case of universal health coverage, we have among countries with 17 to 79 achievement, and we have a long path to full achievement universal health coverage. Based on the UHC cube, actually we cover almost 95% of our population, including the refugees. And in the case of financial protection, we covered 60% of expenditure, and we have also a comprehensive extended benefit package for all the population, including the refugees. But our health system actually is based on the social health insurance. We have 3 main basic health insurance in my country, and the Social Security Organization for private worker and their family, the Army Force Medical Services for the Army Force, and the most important one, the Iran Health Insurance Organization, which actually covered the refugees in Iran, which I more explain about this scheme for health financing for the refugees in the next slide. Actually, Iran Health Insurance Organization have 5 separated funds for covering many different parts of the society, such as rural residents, universal insurance coverage fund for covering the informal sector worker and their families, the Iranian fund for covering the actually self-employed people, the governmental employees, and the most important one, the other sector layer, which covering the 5 different parts of the society, the poor people under coverage of the social schemes, the clergy, the veterans, and the most important one, the documented refugees. Actually, we have started the health insurance for refugees in 2015, the universal public health insurance based on the contract between the UNHCR, Ministry of Interior, and Iran Health Insurance Organization. Based on this contract, actually, the documented refugees divided to 2 main and defined categories: the vulnerable refugees, including the refugees suffering from specified disease such as dialysis, thalassemia, hemophilia, and the poor refugees, actually the women-headed families, and etc. And any other documented refugees except this group as non-vulnerable refugees. In the terms of vulnerable refugees, they have full subsidization in the case of their premium, but about the non-vulnerable, they have to pay full price of their premium out of their package in the point of insurance registration. And as you see in the figure below, actually, I demonstrate the uptake rate of the refugees based on the vulnerable and non-vulnerable refugees during the time. And as you see, the uptake rate is, because of the subsidization, is high for the vulnerable refugees, and the non-vulnerable, because of their the severe economic situation, because of their unstable jobs, and the economic situation in Iran, because of the economic sanctions against Iran imposed by United States of America in the last decade, and parallel with the health crisis because of COVID-19 in the 2 past years, actually they cannot afford to pay premium from their packet, and as you see, their uptake rate is really low. In the case of benefit package, Iran actually, because of integration of the refugees to our national health insurance, actually we have the same benefit package for the refugees equal to the Iranian citizenship. All of the services they could access to all services that the Iranian citizens have access to it. Only the difference point is that up to this year, actually refugees could only refer to public hospitals to receive their needed services, but based on the contract in the 2021, they could refer to private hospital as well. In the case of financial protection, could you hear me? I think some interrupted in the internet. Financial protection, actually the refugees have free of charge access to primary healthcare services, including vaccination, health promotion activities, and etc. And in the case of specialty services in the hospital, actually the documented refugees have to pay only cost sharing equal to national citizens 10% for the inpatient services and 30% for the outpatient services. But unfortunately, undocumented migrants actually they have not any insurance coverage and should pay the actually full price of their services from their packet in the point of service delivery, and this puts them in the verge of catastrophic health expenditure because of the deep gap between the private and public price in my country. But actually, the health insurance scheme for refugees in my country is successful in increasing inpatient service utilization by 52% and could reduce the patient rate in the last decade. We have also additional source of social health assistance for the refugees. The most important one is the social working department in public hospitals, which with the main mission of financially support the poor with their Iranian or non-Iranian. Also, we have some charities such as Mahak Charities, Chain of Hope, or Zanjire Omid, Behnam Deheshpur charities with the main aims to support financially the poor, especially the children suffering from chronic and severe disease. And also Iraqi Refugee Aid Council, Iraq Foundation in Iran, which supports financially the Iraqi refugees in Iran. If I want to share with you a big picture of health financing for the refugees in Iran, Iranian health system, based on the revenue collection, as I said, we have the main flows, financial flows actually bring from international dollars and then Iranian governments and some charities actually. Based on the risk pooling, actually, as I said in the introducing Iran Health Insurance Organization, because of the refugees are integrated in the national health insurance in Iran, actually besides some Iranians such as poor, such as clergy, veterans in the other sector layer found in Iranian Health Insurance Organization, actually there is some level of cross-subsidization and redistribution between the rich and the poor. And in the case of purchasing, I should say that all the strategic purchasing instruments such as benefit package, contracting, payment rate, and method actually is equal for the refugee, and health information system actually is integrated for the refugees in the and the national health insurance. Now I would like to discuss about our challenges in Iran health system. Actually, I think the main challenge is that almost 2/3 of the refugees in Iran are deprived from health insurance coverage because of their illegal residence in Iran, and in the most cases they have fear from referring to hospitals and being identified by government and reported to their origin countries. And they bear a high cost of the health services, and maybe because of that they're seeking services lately, or maybe in some cases they bring out their children from schools and send them to work to can afford health expenditure. There's some socioeconomic features of the refugees, such as high prevalence of physical and mental illness, the low level of health literacy among them, and the unstable jobs and situation and financial problem to meet their needs actually. And the three most important challenges is that because of the economic sanctions in Iran, actually we have some challenges about the financial transfer of money for the international donors, the UNHCR representative in Iran. And as you see in the figures hand side, actually we have a deep gap between the funding needed and funding received by UNHCR in Iran. And the other most important challenges, I think, the non-vulnerable refugees who cannot afford the premium actually price to pay and have the actually health insurance, and the most important one, the undocumented refugees which have not access to any type of the health insurance coverage in Iran. Many thanks, and sorry for the extended presentation.
Thanks very much, Manal. Should we move on to Pallavi? Pallavi, I think you're muted.
Hello?
Yes,
Okay.
now we can hear you. Thank you.
Okay, sorry about that. So I'm here to present joint work with BRAC and LSHTM on healthcare utilization and affordability of key sexual reproductive health services for South Sudanese refugees and host populations in Uganda. This study was done by my co-authors as well as myself, and I'm presenting on behalf of Neha, Joe, who's also on the panel, Zia, Sandra, Munshi. So I'll jump right into my presentation. Yeah. So as Neha rightly pointed out, that there's a need to study utilization and affordability for hosts and refugees of sexual reproductive and maternal health, because the existing evidence is extremely low. Uganda has hosted refugees since 1980, but off late, a lot of refugees from South Sudan, Burundi, DRC, all have been coming to Uganda, and the pressure is increasing on the health system. So statistics outline that 1.47 million refugees are there in Uganda as of now, and of them 903,000 refugees are from South Sudan itself. Also, that Uganda has a unique policy on refugees. They allow refugees to move freely, work, cultivate land, and then access to universal and primary education as well as the healthcare. So refugees don't have to pay anything for accessing healthcare. They don't have to have health insurance. They're able to have to work and cultivate land around in Uganda. They also are living as equally as hosts in Uganda. So this is like a comprehensive refugee response framework under Ugandan government. As Neha had pointed out in her presentation, and I think Manan also touched on in her presentation, that UHC is an important goal towards all of the developing countries are working on. It comes under SDG, and it states that there is an including financial risk protection for everyone. Everybody should have access to quality and essential healthcare services. It should be accessible, safe, effective, and then affordable for everybody. But as much as we would want to achieve universal health coverage in Uganda, the increased arrival of refugees from South Sudan has increased and pressured the health system, and therefore the financial health needs for both hosts and refugees are not being met as per studies. As Neha pointed out, there's extremely limited evidence on the utilization and affordability of these services, and then to what extent they're affordable for both host and refugee communities. Ugandan government has a health sector integrated refugee response plan, which encourages equitable and affordable access for utilization of essential health services for hosts and refugees. They don't require refugees to pay any user fees nor the host communities. And the plan is that everyone would be using the public facilities, and essential funding for healthcare would be jointly funded for host as well as refugee population. So there is no parallel systems of healthcare functioning across Uganda. It stands on like 5 basic principles on equity, integration, universal coverage, respect, and efficiency, all of which I think we've been talking about for this seminar. The essential problem in the health sector for Uganda is that there's a very much gap in the funding from public sector on healthcare. So public spending on healthcare was as low as 5% of the total public spending during 2020 and 2021. So there is extremely limited contribution from the government itself. And that much of these 5%, only 6% of the health spending was for SRH services. Now, the rest of the funding pool is highly dependent on the donors, as well as the private contributions from other players, philanthropic organizations, and others organizations who are working across healthcare sector in Uganda. With respect to the allocation of medical supplies, infrastructure, equipment, all of these have dipped from 2019 to 2020. So you can see an increasing problems of medical supply shortage, drug stockouts, there is infrastructural issues, there are no toilets in some facilities, water shortage, there is no equipment, and in some facilities. So these are increasing problems because the refugees' arrival has strained the healthcare system, especially in the refugee hosting districts. Now, all of this has led to an increase in out-of-pocket expenditure, both for host and refugee communities, has led to inequitable access to care, and then shortage of medical workers and medicines and equipments. To take you briefly through the medical system or the healthcare system in Uganda, there are several layers of decentralized government system from village to parish, sub-county, county, district, regional and national levels, where different ministries are responsible for tackling different level of health facilities. If we start from the bottom, there are village health teams, which are the community volunteers in each village. So they are just responsible for assessing basic knowledge, awareness within the community. So telling community about benefits of ORS, use in diarrhea, benefits of eating iron-rich fruits or vitamin-rich fruits during pregnancy, and so forth. In Health Center 2 and Health Center 3, in Health Center 2, there are mainly outpatient services, which are preventive and promotive in care. So Health Center 2 would cover antenatal care service, immunization programs, all of that. In Health Center 3, the services get more complex. You can there have some components of inpatient care. They can do normal deliveries within them, and then they also have essential medical supplies for family planning and other services, which are also there in some Health Center 2s. For Health Center 4 and General Hospital, they're mostly specialized health facilities for advanced care, so for surgical deliveries or for other health services like blood banks and operations related to that. Referral hospitals come under Ministry of Health, which is the centralized body for taking care of the healthcare system within Uganda, as well as the national referral hospitals also come under Ministry of Health. The essential added-on services are like ENT care, skin allergies, all of that happens in national and regional hospitals. To some extent, general hospitals also offer those services. And from general hospitals and healthcare centers are mostly under district health administration in Uganda. But the funds are allotted to these facilities from the Ministry of Finance, Planning and Economic Development in the form of non-wage recurrent grants. They're also allocated on the basis of the population of host populations only. So while factoring in the grant which the health facility will receive, refugees populations are not involved so far. Then for some facilities are also supported by the results-based financing scheme from the World Bank, where they receive some additional money and then they have to put in definite outputs for that facility, and then that scheme is ongoing in Uganda. A number of development agencies operate under HSIRRP across Uganda, and they support a variety of services. So for example, UN agencies in the form of UNFPA, UNICEF, UNHCR, all of them support the technical teams at national and district level, and they employ skilled workers in health facilities, provide wash facilities, etc. But essentially, because the refugee environment or refugee districts are so strained and the health facilities there are so out of capacities, that most of these capacity building work from the development agencies happens in the refugee areas and not as much in the host areas. So for example, you have agencies like Medical Teams International, World Food Programme, UNFPA supplying the necessity stocks to these refugee hosting facilities, and they have built toilets around on these areas. They've provided ambulances, they've employed their own nurses and staff, they've provided infrastructure support. Some people have also helped in building or facilitating electric generators for the health facilities. So the response, as much as we would want that to be so integrated as per the health sector integrated response plan, it's still not as integrated as the government of Uganda would like. There's a restriction that if anybody wants to do any work in the health facilities, at least 30% of the development funds should be allocated for the benefit of the host population surrounding that area, so that there's no parallel system and host populations are not completely secluded. But this is also low on monitoring, and a lot of NGOs are not following this approach. With the predominant focus on refugee areas, Office of the Prime Minister, UNHCR, and Refugee Agency have gathered the funds for hosting this healthcare integrated plan, but the funding issues remain, because as much as they would want the estimated amount to be funded, only 50% of the funds were received by them during 2019, and I think 50% is also an overestimate of the actual funds they received. So coming back to our study, we did this study in Arua and Kiryandongo districts in Uganda. Both of these are refugee hosting districts, so you can see that Arua and Kiryandongo each have a refugee host settlement. Rhino Camp refugee settlement in Arua and Kiryandongo refugee settlement in Kiryandongo. We selected these two districts because of some key characteristics which make them different. Most of the refugees settled in the Rhino Camp settlement in refugee areas arrived after 2016. So there was a large influx from South Sudan after 2016 in Rhino Camp, whereas for Kiryandongo, most of the refugees arrived between 2014 to 2016, and also some refugees had arrived previously from 1980s or 1990s. So Kiryandongo mostly has refugees which are more settled in Uganda. They've had the opportunity to explore their options, whereas in Arua, they're still quite new to this culture. Then also because Arua is very further from Kampala as well as from the main town. So it takes like around 70 kilometers from the Arua town to reach Rhino Camp settlement, whereas for Kiryandongo, it's just 5 kilometers. So the refugee camp within Kiryandongo is extremely nearby to the town, which makes the access to important facilities and private clinics easier for refugees living in Kiryandongo. There is also difference in populations and the number of health facilities within these two districts. But because they are so big districts, our sample did not cover the whole of the district, but we randomly selected villages from both these districts to make our sample representative of the population. Our essential research question here is that what is the level of utilization and affordability of antenatal delivery and family planning services for refugees and host communities in Arua and Kiryandongo in Uganda? So we are essentially talking about the money they pay for accessing healthcare and to what extent do they use these facilities. We did a cross-sectional survey in both the districts, along with some other qualitative interviews, which included FGDs and IDIs as well. The analysis on that is not completely processed yet, so we are just presenting findings from the cross-sectional survey. We targeted around 2,533 women of reproductive age. We defined women of reproductive age as women between 15 to 49 years of age. We basically divided our sample in 3 categories. One was the ones who accessed ANC and delivery care. We only restricted the women who gave birth in the past 2 years in Uganda. Then we have cost outcomes, where we have focused only on the cost incurred for accessing care at the formal facilities. We have contraceptive usage only for women who have met need of contraception. We define met need as women who are sexually active and are using contraceptive methods. So we did a multi-stage sampling, which was on 2 stages. One was at cluster level and one was at household level. So we first randomly selected the villages. We define a cluster as a village, and then we randomly selected the households within each village. We did a t-test and chi-square test for descriptives, and then followed a 2-part model for reporting the marginal effects on characteristics. To essentially run you through the key participant characteristics, we have 25 women around 25 years of age as average. 78% of the refugee population under our study arrived between 2014 to 2019. Refugees were more likely to be educated and to secondary level and have a female household head, higher expenditure, and receive cash or in-kind support. Whereas hosts were more likely to be married, having delivered a child in the last 2 years, engaged in paid work. The essential findings we have here is that for ANC, we find that overall 97% of the women accessed ANC at least once in their pregnancy, and then over 70% had for 4 or more visits in the antenatal care facilities during their pregnancy, but we find slightly higher magnitude for refugees as compared to hosts, although the difference is not very significant. At the place of which the access of ANC happened was refugees accessed ANC mostly at the refugee health centers, whereas hosts also accessed ANC at the refugee health centers. So we can see 12% of the host population accessing care at the refugee health centers, and then we have 6% accessing at hospitals. So this calls out to say that refugee facilities have better care. Then we have ANC, which is also more, we have more refugees paying for ANC at antenatal. So I'll just quickly run over because I think I'm running out of time. We have refugees accessing more care at facilities, so they are more likely to deliver at the facilities. And then I think I can jump onto the conclusion in my presentation just to say what are our findings. So basically, refugees have better access to antenatal care and delivery care, and they're less likely to pay as compared to hosts. We also find that medical cost of delivery is higher for refugees, and this is essentially driven by cost of dignity kits. These reasons are stockouts, and then hosts can obtain dignity kits at the refugee health centers. We also feel that 30% of refugees are with only met needs, so there is greater sensitization to be done on access to family planning services. And then except for transport and contraceptive costs, only average out-of-pocket expenditure was higher for refugees as compared to hosts. The takeaways would be that we need to further strengthen the integration of host communities in SRH care. Then we should have greater sensitization of refugees and host communities for accessing family planning care. We should improve the transportation services for host communities so that they can better access facility-based deliveries, and then allocate more funds to SRH care. Sorry about the rundown, but please feel free to reach out to me if you have any questions on the research. Thank you.
Thank you so much, Pallavi. So we'll have our last presentation by Rapi Pong now. If you would like to share your screen.
Right, so So would you like me to share the screen, or you share the screen for me, whatsoever?
I think you can, or
yeah.
I don't
Okay.
know.
So
Yeah.
so better. That's I
Yes, because I don't have your slides. Yeah. Thanks.
All right. Okay. Hold on. Right. That's what's next. Okay. Can you hear me? Right.
Yeah.
So
Perfect.
this is a study that we did not in 2021, but actually it was performed in 2019. I would spend around 10 or 12 minutes to talk about this research and not delve into the details of the research findings, but to give you an overview of the healthcare service system for urban refugees in Thailand. Therefore, I will skip some of the slides, but I'm happy to share you afterwards if you wish to see the full presentation. And this is the slides that we share to the policymakers in Thailand when we discuss the research findings with them. First of all, I will skip this one. So this is the overview of the healthcare. Actually, it's just the health insurance systems for a non-Thai population, if I may say. You can see that we have around 3 to 4 million non-Thai population, and the majority of them are, the majority of them were those who were insured with the Social Security Scheme, and we call the Triple S scheme, Social Security Scheme. These are for, this is for the high skilled migrants, or they can be low skilled migrants if they work in the formal sector. And we have another one, the purple one, which is the insurance card scheme for migrants in the informal sector, which are most of them are low skilled migrants. Okay, the low skill is the term that I quite disagree, but most of the time we call them low skilled migrants. But okay, I will refer these people as low skilled migrants. They are insured by the Ministry of Public Health. This scheme is called the Insurance Card Scheme, or the HICS, HICS. We have stateless people, which are already insured by stateless insurance. We have refugees, and we have two types of refugees. First, the yellow one, I call them the camp refugees. Some people call them refugees in the shelter areas. They are, most of them are border people who fled from Myanmar long ago in 1988. And there are still some refugees from Myanmar crossing the border into Thailand every day. These people are covered by UNHCR and the NGOs. And many NGOs, in cooperation with the Ministry of Interior in Thailand, they manage the shelters for them for over 20 to 30 years, but they still call temporary shelter areas. And we have the rest 1%, quite small in number, but this is the most negligible group. We call urban refugees. Most of them are in Bangkok and in some provinces nearby Bangkok. Why these people is important? I would like to show this slide. If you look in the Medline, like in the literature, you can see that we have quite a very few number of papers or studies regarding urban refugees in Thailand, let alone the fact that the Ministry of Public Health or the overarching government did not provide a systematic health insurance for them. We have health insurance for migrant workers. We have health insurance for stateless people. We have some people who are responsible for refugees in the camps or in the temporary shelter areas. But we left 1% of the population urban refugees. So when we say we already achieved universal health coverage, we have to look into detail whether we really achieve universal health coverage like we try to broadcast this achievement to the world. So this is something that I would like to, I and the team always challenge the government. However, even though these people are quite small in number, the healthcare system management for them is quite challenging, perhaps even more challenging than migrant workers or undocumented migrant workers. Why? I will show you something. This is so that's why I would like to show you the whole picture of the insurance scheme for migrants first, and then we delve into detail about this study. These studies has 3 objectives. First is to review the policies and regarding the care for urban refugees in Thailand. Sometimes I call them URAS, URAS, which is urban refugee and asylum seekers. And the second objective is to explore the attitudes and perceptions towards urban refugees amongst policymakers and health practitioners, as well as the academia in Thailand. And the third objective is to explore the unmet need for healthcare services in URAS or in urban refugees compared with the Thai citizens. Okay, I will go quickly into the results. You can see that if you look at the international policies related to URAS in ASEAN, by Thailand, okay, it's the second rightmost column. We are in the second rightmost column. You can see we already ratified almost all the international regulations, except the only exception is the 1951 Refugee Convention, which is quite interesting. The only 2 countries in ASEAN that are already the signatory of this convention is the Philippines and Cambodia. But okay, we will not criticize or ask them whether they have performed well or not, conforming to this convention. But look at Thailand first, because Thailand is the focus of this study. We ratify every conventions except the Refugee Convention. Note that Thailand already ratified the Global Compact for Refugees, but we try not to mention the Refugee Convention. We have our own laws or our own bylaws. Most of the bylaws are about the Immigration Act or the Civil Registration Act, or which is something related to migrant workers, but we have not explored anything about urban refugees. In other words, the Thai law does not recognize urban refugees. I have to say that. But anyway, in the past few years, especially in 2019, there is in the UPR, the Thai Prime Minister, that was the first time that the Thai Prime Minister recognized the existence of urban refugees. So they try to sweep and clean all these people again by endorse the so-called the regulation of the Office of the Prime Minister on the screening of aliens who enter into the kingdom and are unable to return to the country of origin, which is quite interesting. Even the title of the law, they try not to mention urban refugees. Why? That I'm quite interesting with the mentality of the Thai law. So we try to interview and perform a quick Delphi survey amongst policymakers, and we try to identify some themes that can explain the mentality of the Thai healthcare system or the Thai laws, why they try not to mention urban refugees. First of all, we find that the Thai government position, this is the first team in the leftmost column. We find most of the time, I find that some people say that the Thai government position is unclear towards urban refugees. I would like to argue that no, this is not true. The Thai government position is very clear that they try to be unclear towards urban refugees. Why they try to be unclear? Because if they are very clear that they would like to take care of urban refugees, they will be facing with many international pressure that they have to accept urban refugees. But they try to keep a benevolent image that, okay, even without the 1951 Refugee Convention, we are happy to take care of urban refugees. But let us do this hiddenly, not openly. So we can manage our own system without any pressure from the international peers. Because if we accepted the 1951 Refugee Convention, we would be pressured so much by the global health arena. So this is the second team. There were diverse opinions on being the signatory of the 1951 Refugee Convention. This comes to the third team, which is that we found that because of the unclear position or unclear direction of the government, there are variations in the healthcare services in the public sectors. Therefore, this creates room for the NGO or civil societies to step in to help urban refugees, which is good or bad. It can be the two sides of the coin, right? The NGO can step in because of the weakness of the public system. But once the NGO step in, it means that there is no sustainability of the service system. So then, and these are some minor themes. Like we have diverse opinions on the health insurance for urban refugees. We found that most urban refugees have lots of work potential, but they are not allowed to do so. Actually, they are very like migrant workers in terms of skills. Some of them are more skillful than Myanmar migrant workers. Some of them are health professionals. However, the domestic laws do not allow them to work. Unlike refugees from Myanmar or Cambodia, this is quite interesting. It seems like the Thai government accepts the existence of undocumented migrants from Cambodia, Laos, and Myanmar, or CLM migrants, but not the existence of urban refugees. And this creates the last theme, which is urban refugee living situation, which is like they are living in the vacuum. They cannot go, they can go nowhere. They cannot go back to their own country, their home country. They cannot, okay, very few of them can seek refuge to in the third country with the assistance of UNHCR. But UNHCR cannot do much on the Thai territory because Thailand is not the 1951, is not a party of the 1951 convention. So you can see the vicious cycle among the urban refugees' life. The last objective is to compare between the urban unmet need for health services between Thai population. This is a national representative survey done by the National Statistical Office of Thailand with the primary data collection on urban refugee, which were conducted from my team. And we combine these samples together using the same set of questionnaire. So we can compare the Thais and urban refugees because we use the same set of questionnaire. And it is the questionnaire called Unmet Need for Health Services, which is developed by the EU. You can see this figure, like the prevalence of unmet need in Thai compared to URAS or urban refugees. You can see an extensive difference between the Thais and the URAS, right? Those who have unmet need are shaded in dark blue for outpatient services and dark yellow for inpatient services. You can see the difference is around 10, is more than 10-fold. Sorry, I have written it in the box. The difference is around 13 to 26-fold. And with some mathematical analysis, like we use mixed methods model to analyze, and we found that the factors that contributed to unmet need is whether they are insured or not insured. All Thais are insured by law. All urban refugees are uninsured by law as well. So we can see that the having or not having insurance is the main contributory factor for unmet need for health services. Other factors are unmodifiable factors like age, sex. I will not talk about that issue. And this is some subgroup analysis. We found that amongst the urban refugees, those who are from outside ASEAN, like from Afghanistan, from Palestine or Iraq, they have greater degree of unmet need compared to those originated from China or Southeast Asia. So in conclusion, I think the ideology of national security and international relations had influence over the concept of human rights in US, in Thailand. And this creates the ambiguity of the policy direction. But the Thai government tries to keep this ambiguity. And this creates the greater prevalence of unmet need in URAS compared to the Thais. Having insurance, the absence of insurance is the main contributory factor for unmet need for services. What can I recommend? I'm not sure. Perhaps I think we need to reorientate our healthcare systems. If I say the policy recommendation is that the Thai government should demonstrate a clear direction, this is contradictory to what they try to do so, right? So perhaps this is not a good policy recommendation. Perhaps the good policy recommendation is that we have to ask our colleagues to force the Thai government in the UPR, something like that, to let them change the position. But anyway, in the short term, I think there's something that we can do. For example, the law that provides a work permit for non-Thais, they can be extended to cover URAS very easily if this law passes through the cabinet. No need to rewrite the law in the act or in the decree. So this is the mechanism in the law. Having said that, I mean, by open rooms for URAS to work, this is a short-term solution, because by letting them to work, they can access. This system can ease their financial difficulty, and if they have if they can earn some money from work, they can buy insurance by themselves. So the government can say that this is not the insurance that provided by the government, but URAS can buy the insurance for themselves. At least I'm not saying that this is the permanent solution, but at least it is some backlogs in the system, because they can work, they can access to insurance, they will have lower degree of unmet need. But in the long term, it's up to the Thai government whether they wish to extend their services to urban refugee or not. So thank you for your attention. This is just my short presentation.
Thank you very much, Rapipong, and thank you to all the speakers for all your presentations. So just to let you know, I'm sorry we've overrun a little bit. Maybe that was a bit optimistic to have 4 presentations in 1 hour. So now we'll hear from Joe, who's gonna reflect on the findings and provide some insights on all these presentations. And we'll try to have a quick Q&A at the end. We'll try to keep it under an hour and a half. So Joe, over to you.
Thank you, Manon. Let me just quickly share my screen. Oopsie. Okay, so oh, sorry, doing some strange things here. Hopefully you can see my screen okay. Great. So, sorry, I'll keep this brief as I know we're a little bit tight on time, but I mean, I just wanted to just highlight again, well, thanking obviously all the speakers for their really insightful and interesting talks. So we've got this context obviously of growing refugee numbers, which is only going to increase over time. And the majority of the refugees we know are being hosted by low and middle income countries, such as the countries we've just heard from. And some of these countries are obviously already struggling to achieve universal coverage. So there's a real financing issue there. We've heard from Iran and from Neha the important role that the UNHCR is playing in currently funding premiums for vulnerable groups, providing cash transfers and supporting insurance in a variety of settings. But the UNHCR is massively underfunded, and at the moment half of its funding is only coming from 5 donors. So there's a real concern about sort of the long-term financial sustainability there. I just wanted here just to kind of flag up the different countries that we've heard from, and just it's quite interesting. I think we've heard from Uganda, where government funding, and then Iran and Thailand with high levels of UHC, and all quite different sort of approaches to financing refugees. I think one thing that really stood out is maybe the importance of the legal status and the right to work of the refugees, as Poon just highlighted, both in terms of having access to insurance schemes where they exist, to make the payment of premiums or out-of-pocket payments more affordable for refugees. And I guess the other sort of issue there is the sort of degree of alignment of the financing mechanism with that of the local or host population, and where there is greater alignment or integration, as is the case, for example, in Iran, where we heard the refugees are fully integrated in the Iran Health Insurance Organization. Obviously that reduces fragmentation, potentially increases efficiency, but also provides better access to care. And equally, obviously in Uganda, where the tax-funded system allows full access, in principle, at least to all. And we even saw that the refugee population has slightly better access to reproductive health services. So I think I'll end there. I had some questions of my own, but I really am keen for those of you who are with us to have a chance to ask questions first. So I think please do, if you've got any questions for the speakers, please do share them with us. If you want to just comment or reflect on maybe experience in your own country and how that relates to what we've heard, that would also be really great to hear.
Thank you very much, Jo. So we have one question here. So does UNHCR have a coordinated healthcare financing strategy for refugees? Actually, yeah, I was also wondering about this, about the extent of the political lever that the UNHCR can have in different countries. What's the extent of their power, basically? I guess that's the question.
I don't know if anyone on any of our speakers feels able to speak to that question.
I think that Manal. I think that UNHCR could not force countries to finance health services for the refugees. But I think that in every country, especially the biggest host for the refugees in worldwide, I think that UNHCR work its best to actually create motivation and negotiation with the governments to actually put the health of refugees in the agenda and actually engage the government of the host countries to involve themselves in the health of their refugees. I think this is not this is a voluntary basis activities in any countries. But I think at the same time, based on the actually the agenda, international agenda, especially the 2019 in the New York, United States of America, actually because of the two article of 17 and 17.1 of the UPHT agreement among the countries. Actually, this is now a right for the refugees to have equal access and affordability to access health services. So this is not the countries now actually have the duty to financing health services for their refugees, I think.
Thanks very much.
I think also just to quickly add that for UNHCR, there are quite a lot of, if you look for them, there are a lot of strategy documents. But I think the way, so for example, they have a strategy on cash-based interventions. But the way that it's actually operationalized country to country is very different. And that's also because the funding levels for UNHCR itself, region to region, is quite different. So yeah, I do think you'll see some joined up thinking in their sort of higher level strategy or policy documents. But as I said in my presentation, there's a sort of $15 billion shortfall in humanitarian financing at the moment, or at least in 2016. And I think it's only increased in the last 5 years. So the actual implementation of how this works country level and country to country and setting to setting is quite different.
Okay, thank you. Thank you for the link, Pallavi.
Mm-hmm. So just to add on, Neha, for Uganda, they have an integrated refugee response plan. So they cannot have a separate financing strategy for refugees. Everything is now aligned with the Ministry of Health. So this comprehensive refugee response plan is to build on that for Ugandan's case.
Okay.
So sorry about that. I just lost my connection.
So did you have any question for the speakers? Or?
I did have some questions, but I've just seen the time. I'm supposed to be picking my son up from school. I'm so sorry. Yeah, I had a slide of questions, but
yeah, I think we've overrun a bit. Maybe you can continue the discussion on the side. I'm sure we'll
that would be great.
Continue, and even at IKEA, I mean, because I think it's going to be one of the session, right, at the Congress.
Yes. No, sorry, it's not finally. It's not, no, we were hoping it was, but no, it's not in the end.
Okay, all right. Okay.
But definitely it'd be great to continue the conversation, and thanks so much for the great presentations. I think it's lots of food for thought. It's really stimulating.
Yeah, thank you very much for this, everyone. So if we don't have any more questions, we'll leave you to pick up your son, and I'm sure we all overrun. So thank you very much on behalf of the special interest group at IKEA, and yeah, I wish you a very good day, everyone. Thank you so much for your time.
Bye.
Thank you.
Bye, everyone.
Bye. Bye.
Thank you. See you then.